Good afternoon. It is so wonderful to be back in person and seeing everybody here. It's fantastic. I'd like to start by thanking the PDC and the program committee for this terrific privilege and opportunity. And it'd be remiss if I don't mention that I wouldn't be where I am now today without the unwavering support, the love, the sponsorship, the mentorship of APSA, APSA leaders, and my own board of directors, so to speak, and above all, UAB and Children's of Alabama. Mike, Liz, Mac, I love you guys. So let's start about a topic that I'm very passionate about. These are my objectives. As you all know, nowadays, two-thirds of the diaphragmatic hernia cases are diagnosed by the second trimester. I want to argue that an antenatal diagnosis of CDH should be considered a risk factor for subsequent outcomes. The overall neonatal mortality in prenatally diagnosed CDH is almost 70%. And as you all know, pulmonary hypoplasia and pulmonary hypertension are the main causes of death in isolated CDH. And that is due to the disruption of pulmonary development during the pseudoglandular stage. The majority of these cases are types C and D and are associated with multisystem morbidities. So let's shake it up a little bit in a classic Mac Harmon fashion. How would you all respond to this, and how would you counsel this family? A 28-year-old G1PO female presents with a singleton pregnancy complicated by a left-sided CDH. The OE-LHR is 22%, liver is up, no other associated anomalies, and amniocentesis normal karyotype. Would you counsel them that feto in severe prenatal CDH is not helpful and is considered experimental, recommend comfort care? Would you counsel the parents on protocolized postnatal therapy? Would you recommend an exit to ECMO approach? Or that the benefit of prenatal intervention on survival is solid and you would recommend feto? I'll give you guys a little time, and Nate here, my buddy. All right, so I think this is exactly what I expected. It's a split between protocolized postnatal therapy and feto. The take-home point number one, optimal perinatal management of CDH rests on 1, prenatal imaging for evaluation and prognostication, followed by multidisciplinary prenatal counseling, and ultimately a planned delivery at a tertiary or a quaternary center. And this is important because it allows you to provide appropriate family support and resource utilization, identify high-risk patients in need of advanced postnatal care, and it offers an opportunity for triage and discussion of possible prenatal intervention. Prenatal assessment should rest on objective identification of the degree of pulmonary hypoplasia, identifying pulmonary hypertension, liver herniation, and ruling out major associated defects and chromosomal abnormalities. And this can be accomplished by a detailed fetal ultrasound. It's an anatomical ultrasound, and that's important because, as you all know, 40% of these cases are associated with other defects. The fetal MRI might be helpful because of one of two things. It provides a little bit of an enhanced anatomical detail, and it allows you, excuse me, to quantify liver herniation. A fetal echo is important because 10 to 15% of these cases are associated with cardiac defects. And those are the isolated cases, but all comers, it's up to 40%. The other thing that it's important is evaluation of the degree of left ventricular hypoplasia, and that's extremely important in CDH. And then ultimately karyotyping and microarray analysis, because up to 33% of these cases will have a cytogenetic aberration. The sonographic assessment of pulmonary hypoplasia needs a couple of things. One, measurement of the lung size, which is either a two-dimensional approach using an ultrasound to obtain an LHR or an OE-LHR, and an ultrafast fetal MRI. Evaluation of liver herniation could be a dichotomous, yes, present, or no, it is absent on ultrasound. But to quantify the degree of liver herniation, MRI is the method of choice. While antenatal assessment of pulmonary hypoplasia has been validated, it's been studied, it's great, that of pulmonary hypertension is still a work in progress. The lung-to-head ratio was first described by Metcalfe in 1996. This is the formula up there. In order to obtain a two-dimensional lung volume, you have three methods to get that, either the longest anteroposterior diameter, the longest diameter, the anteroposterior method, or the trace method. A recent NAFNET study demonstrated that the trace method is the most accurate with less inter-observer variability. But it's important to recognize that between 12 and 32 weeks of gestation, there's a 16-fold increase in the lung area, but only a concomitant four-fold increase in the head circumference. Therefore, it is crucial to take that lung-to-head ratio and then take into account the head circumference. And this was described by Peralta to obtain the observed to expected lung-to-head ratio. Moreover, most of these studies are performed in early gestation. Their predictive ability in fetuses beyond 30 weeks should be interpreted with caution. The MRI will allow you to get total fetal lung volume, percent predicted lung volume, and similarly, the corrected observed to expected total fetal lung volume as described by Ripens. Take-home point number 2. In centers with restricted access to ultrafast fetal MRI, the ultrasound measurements utilizing the trace method are adequate for the initial assessment and triage of these patients. I.e., you don't have to get a fetal MRI, and this is coming from somebody who is very passionate about anything that has to do with fetal. The second point is the performance of OE-LHR using the trace method is similar to performance of OE total fetal lung volume. Both are superior to other parameters predicting survival. The clinical spectrum and survival of prenatally diagnosed CDH is depicted in this graph and schematic. And these are 4 different series that are amalgamated together. So basically, when looking at these, you can either have a mild CDH, and those are defined by an OE between 35 and 45%. Those babies are characterized by mild degree of pulmonary hypoplasia, good gas exchange, with an expected survival up to 80%. Moderate cases are those with an OE between 25 and 35%, or 35% and liver up. They are characterized by a reversible pulmonary hypertension, but they have a marginal gas exchange and clinical ability. And then ultimately, the severe cases with an OE less than 25%, and those have severe fixed hypoplasia with an expected survival less than 35%. So when you start thinking about, okay, antenatal intervention, obviously, mild cases, nope. Moderate cases was a question, but it was the severe cases that it made some sense to say, you know what, are there prenatal interventions to allow us to promote lung growth? As you all know, CDH survival is tied to the gestational age of delivery. Previous studies by Kojan-Sao and the CDH study group, and similarly, FETO Consortium, demonstrated that survival of CDH is maximal when it's beyond 32 weeks of gestation. This is really crucial and was very crucial when designing the total trials. So the total trials hypothesis, the severe trial, was that FETO compared to expectant management, followed by standardized postnatal care, increases survival to discharge from the NICU. So severe cases underwent FETO between 27 and 29 weeks, reversal at 34 weeks, and the primary outcome was survival to discharge from the NICU. Let me be very clear here. The total trial was not powered for morbidities or any secondary outcomes. Survival to discharge from NICU and 6 months without oxygen. In looking at the results of the total trial, there was a clear benefit following FETO, 40% versus 15%. But that came with a significant risk, right? You all know premature rupture of membranes and preterm delivery. I would argue that when considering the total trial, you have to take into account the unintended consequences of any very successful fetal trial that took 10 years, right? So the ability to standardize care during the study's 11 years across 10 different fetal centers. But what's interesting in this is the survival in the expectant group is extremely low, 15%, with an ECMO utilization of only 29%, a little bit bizarre, right? In the United States, on this side of the pond, it's a little bit different. And there are up to 50% non-repair rates. That's a little odd. Very quickly, the take-home point 3 here. For the moderate diaphragmatic hernias, fetal did not increase survival, and it came with pretty significant risks. But I gotta tell you, as somebody who is pretty interested in stretch-induced pulmonary growth, fetal in these moderate babies was done at 30 to 32 weeks, going back to Koshin's study, because they wanted to avoid any risk of having a baby prior to that 32 weeks. So might there be a different outcome in the future? Who knows? So what do we do with severe CDHs in the United States? And what about the contemporary outcomes over here? Will the balance be shifted, tipped over to the other side? I'd like to share that the contemporary outcomes are going to be popping up here pretty quickly. And I'm just going to offer a glimpse of my personal experience on the CDH team between 2014 and 2019. We had 11 severe diaphragms with an OE less than 25%, 100% CDH repair, 45% ECMO utilization, very similar to other centers. But our survival, 1-year survival was 64%. This is clearly higher than that of the total trial. And I can tell you through personal communication that the NAFNet contemporary outcomes and Dr. K's outcomes are going to be very similar. So take home point number 4. The current state is, I would argue that there shouldn't be any discussion about whether or not tracheal occlusion will lead to a stretch-induced pulmonary growth. Obviously, yes, absolutely yes. And it confers a survival benefit in a subset of the most severe cases. But you gotta remember, it comes with an inconsistent pulmonary vascular response. Our lab hypothesized that the hallmark in understanding the biological response to fetal is to view it from the perspective of heterogeneity. It's fascinating. We've been able to demonstrate that there is a heterogeneous local metabolic landscape, ECM heterogeneity, variable proliferation rate, and a diverse scale of vasculogenesis and angiogenesis following tracheal occlusion. So I would like us to shift from the concept of a bigger lungs to that of functionally appropriate lungs with a normal pulmonary vascular tree. I think we need to shift the primary outcome assignment from a focus on mortality to that on morbidity. And that standardized approach to assessment of a fetal pulmonary vascular tree, uniform diagnosis of what is postnatal persistent pulmonary hypertension, and objective criteria for ECMO utilization. Those are the things we need. I would say that when you look at the total trial, you always have to think about contemporary outcomes, and that should be the catalyst for 2 things: collaboration, future innovation, because I think the future is much brighter than where we're at right now. I'm gonna offer a few things, a paradigm shift. ECMO, not as a rescue, but as an adjunct. I think about it that way. An early repair on ECMO, obviously the postnatal advancements in critical care, and the concept of resting the lung and allowing pulmonary growth and vascular remodeling to occur. So the current recommendations are a moderate CDH. This is for protocolized postnatal management with a dedicated multidisciplinary team, use of ECMO, and early repair on ECMO. For the severe cases, I think there are 2 options. One, either refer them to a fetal center to discuss the risk profile of tracheal occlusion, or refer them to a specialized high-volume center for contemporary protocolized management. And I'd like to leave you with some thoughts. The total trial had a 40% survival. Contemporary outcomes in the United States, I will tell you, they will be more than 60%. So will fetal plus protocolized care in the United States improve survival beyond 60%? Will fetal decrease ECMO utilization potentially decrease morbidities? And is it time for a US-based trial? Lastly, the technical advancements in fetal, smart tracheal occlusion, the study of the temporal effect of occlusion, membrane stabilization so that we don't have to worry about the second hit and preterm rupture of membranes and prematurity, and the use of biological modulators, not only the pulmonary stretch-induced growth, but the pulmonary vascular development. And I would argue that the future for prenatal CDH will be bright, and I believe so. And with that, thank you again for this terrific opportunity.
Thanks very much for a very important topic, extremely complicated. And I just wanted to point out a couple things. We just got back from the CDH meeting in Glasgow, and we do have some data back from NAFNet about the NAFNet group of feto patients. And it does look as if survival is equivalent between the feto and non-feto groups, which is quite striking. It is retrospective, not prospective. The other recent data from Dr. Perron and the CDH study group registry shows that survival for the severe group of CDH patients overall in the registry is about 40%, not 15%, not 25%. So I think things are improving, we're getting better at management, and I think that along with improving feto and how we intervene prenatally, we need to focus on standardization of care and improving how we take care of these babies after delivery. Because not everyone's going to have access to prenatal care. We don't have a consistent prenatal diagnosis, and we all have to know how to take care of these babies no matter where they're born. So,
Thanks, Tim. Yeah, I totally agree. I think, if you look at various centers who have spent their entire career focusing on this important disease, if you protocolize management, if you protocolize everything and you follow, the evidence, you will have better outcomes. I think I was surprised by the fact that, survival is only 15%. And that's why, I didn't share the details, but, I only shared the glimpse of my personal experience. And I think we're going to continue to get better. I mean, we've moved from, delayed repair on ECMO to, rightfully so, early repair on ECMO with an anticoagulation protocol. And like other centers, you see great outcomes. But I'm also a firm believer that stretch-induced lung growth is absolutely real. I think the idea now is to try to make it not just, like I said, bigger lungs, but they're functional lungs, and not necessarily rely on an occlusion to end up with a lung that is blowed up and less compliant, so to speak, but the pulmonary vascular resistance hasn't changed. And we've all had some of these tracheally occluded babies where some of them have no pulmonary hypertension and some of them have horrendous pulmonary hypertension, and we don't know why. Dr. Stoller.
Yes, I want to thank you for a very balanced and honest discussion of a very controversial topic, number one. Number two, I'm sorry Jay Wilson's not here, but we owe a debt of gratitude to him for his first presentation about tracheal occlusion when he showed that slide in a lamb model of the lung herniating through a created defect in the diaphragm. Number three, I want to remind everybody of what I think is a very important piece of work done by Holly Hedrick a number of years ago in an animal model of diaphragmatic hernia with tracheal occlusion, where she showed that the gas phase of the lung, the growth of the gas phase of the lung is discordant with the growth of the blood phase. It lags substantially behind and leads to a fixed cross-sectional surface area once the animal model is born. And I suspect that's a large part of what we're dealing with here. And that's why the pulmonary hypertension, despite remodeling, is fixed in stone once these kids are born, just absent some remodeling. So I would encourage us to look at human specimens and look at the relationship between the gas phase of the lung and the blood phase of the lung, because they're discordant. And finally, regarding the total trial, some of you may have read the letter to the editor that we published in the New England Journal and the longer piece in the Journal of Pediatric Surgery, co-authored with Alan Flake, Paul Losty, and Jay Wilson. Very critical of the total studies for many of the reasons that you alluded to. Not that this wasn't a Herculean effort to do this. Over 10 years, of feto centers where they did not take care of the babies after they were born. They returned to original hospitals. They had variable experience, not only with taking care of diaphragmatic hernia, but with extracorporeal life support, and with changes in the standard care leading to data, in our opinion, that was largely uninterpretable. And finally, I agree with you completely that the outcomes in the United States, in large part due to the respiratory care strategies that came from my former institution, had on the outcomes of diaphragmatic hernia that are not generally practiced in Europe. So yes, if you want to do a trial in the United States, I'd be all for it. But keep in mind that our standard of care and our outcomes are different from what was reported in Europe. And I would hope that if a domestic trial in the United States is done, it's in a much more controlled, honest way. Thank you.
Thanks, Dr. Gold, for these comments. Yeah.